Good afternoon. I'm Toby Weingarten. I am a professor of anesthesiology from the Mayo Clinic, and thank you for staying around on this beautiful day. And thank you to Arnie Abseko for inviting me here. I'm going to talk to you today about postoperative respiratory depression with a focus on how the phenotypical presentation and when the temporal distribution of these events occur after surgery. So when we talk about respiratory depression after surgery, I think it's important to understand this continuum of severity of this. It could be, mild self-limited respiratory depressive episodes, may even be just a slight exacerbation of underlying sleep apnea. It could progress all the way to death. When we look at the more mild cases or self-limited cases, the Sun-Z paper from the Cleveland Clinic showed about 37% of patients had spells of hypoxemia less than 90% for greater than an hour. When we used capnography with the Prodigy trial, we found 48% of patients had respiratory depression. Now, these were mostly self-limited episodes. When we're thinking about more critical episodes, if you use naloxone as a substitute, there's probably an N of around 850,000 patients who've been in cohorts where they've looked at postoperative naloxone on the wards. And it really comes down to about 1 in 1,000 patients is the incidence of somebody is discharged from the PACU, they go to the regular floor, and they get naloxone. Now, when we looked at capnography, the Prodigy trial, we looked at 7 countries, 3 continents. We had 1,300 patients enrolled. And again, we found 48% patients had respiratory depression, and we came up with a prediction model using 46 different risk factors that we looked at. What was very interesting in the Prodigy trial was how respiratory depression presented. So you see in those lines there, the blue lines are exhaled carbon dioxide, the red line is SpO2 from a pulse oximeter, and the green line is the heart rate. And you'll see that the patient is having normal breaths, exhaling the CO2 in the mid-30s to 40s range. But then there's these gaps of partial apneas or total apneas. And this patient is on room air. So you see these very nice declines in the SpO2 associated with that. When patients are on supplemental oxygen, you can see that the SpO2 remains normal despite apnea patterns. When we looked at the most common pattern that patients had, 97% had some component of apnea. Okay? They do this over and over and over again. These are 4 examples of the Prodigy. The top left shows your typical apnea pattern with decreasing SpO2. The top right shows isolated bradypnea. And this is what oftentimes textbooks suggest, or what I think nursing staff look for when they're assessing patients for opioid depression. This was extremely rare, less than 1% of all the respiratory depressive episodes we saw in Prodigy. People don't typically do this. And you can tell it's kind of spaced out breaths. Very, very, very uncommon. The bottom slide shows a patient has a very profound apnea. Their underlying SpO2 is low, so there's probably an underlying degree of VQ mismatch, probably from atelectasis. And this patient has a prolonged hypoxemic response. The last one is really interesting. This is one we actually captured somebody getting naloxone. This patient had over 20 episodes of apnea before the naloxone was administered. And it's very interesting when we read the adverse report for that. The adverse event report was that this patient was having somnolence, not respiratory depression. So this patient with capnography is clearly having episodes of apnea, but the healthcare providers did not appreciate that. So what do most healthcare providers see? Well, if you look at the Lee study looking at closed claim events from opioid-related harm, somnolence was appreciated 62% of the time. We've done several studies at the Mayo Clinic looking at postoperative naloxone, and we see that frequently sedation is appreciated by the nurses, sometimes more so than respiratory depression. Why is that? Well, we conducted a simulation model at Mayo where we took floor nurses from a standard surgical unit, and we had them assess a model that was either having apnea pauses or just isolated bradypnea. The first thing the nurses did when they walked in the room was wake up the patient. Hi, Mr. Johnson, I'm nurse so-and-so. I'm going to assess your vital signs. If someone is sleeping and having opioid-related sleeping disorders and they're still able to be aroused, you're extinguishing the disorders. And they were unable to appreciate the apnea model in 90% of the cases. So what are risk factors for having respiratory depression? When we look at the Prodigy model, we found that age was the most important risk factor for having respiratory depression, especially patients over the age of 80. Male sex, opioid naivety, OSA, and heart failure. Now, again, the Prodigy were self-limited episodes of respiratory depression. When we look at the Mayo Clinic naloxone studies, we found certainly OSA increased the risk, debility increased the risk threefold, heart disease 2.5-fold. Having CNS disease, so dementia, Parkinson's disease, really increased a 4-fold increase. Also, patients using gabapentinoids were at much higher risk for having respiratory depression requiring naloxone than patients not on those medications. We focus a lot on obesity. I've never really seen an obesity signal. Probably it's the other way, with thin people are higher risk. Cachectic patients, patients who are malnourished, are higher risk for getting severe opioid-induced respiratory depression than big people. Who are you more worried about? I'm more worried about Guy's parents than Guy. Okay. The other interesting thing that we've noticed at Mayo is that the PACU can really predict who is going to get into trouble on the floor. And so I always make the analogy that the PACU is a canary in the coal mine. It'll tell you when trouble's coming. The studies that we've done looking at patients who are having isolated episodes of respiratory depression in the PACU went on to wake up and then go to the floor were at 5-fold higher risk of it getting Narcan on the floor compared to similar controls. Patients who got Narcan in the PACU or in the operating room to wake them up also went on to have much higher rates of having problems on the floor than patients who did not have that. A study that I was not involved with, they used the bioimpedance monitors to measure respiratory depressive episodes in the PACU, and they dichotomized patients if they had problems at the beginning, at the end 30 minutes of the PACU, or not the end 30 minutes of the PACU if they had respiratory depressive episodes. And what they found is when you go back to earlier in the PACU stay, those who had respiratory depressive episodes the last 30 minutes were those who had respiratory depressive episodes at the beginning of the PACU. When you look at those patients after they left the PACU, they continued to have respiratory depressive problems for greater than 12 hours compared to the patients who did not. So this behavior in the PACU continues on the floor. These are some unusual 24-hour clocks we developed from the Prodigy trial. So these are 24-hour clocks, so it's midnight, 6 a.m., noon, 6 p.m., midnight. And as you go farther out from the center, you have higher rates of incidence. So the first one is, when did patients first start developing respiratory depression with capnography? The red line shows when surgeries were done. So in this trial, usually between 10 and 2, they were in the PACU not being monitored for capnography. When they went onto the ward and the capnography device was starting to apply to them, we began to observe apneas right away. When we looked at the cumulative, all the apneas that they had, we got this bilobed picture where we have a large number of events occurring in the evening and a large number of events occurring in the middle of the night. Okay. So which one is more scary? Which one are we more concerned about? We look at the Mayo data of when patients get naloxone, the same 24-hour clock, we see that the patients are mostly having Narcan shortly after PACU discharge when they go to the floor. So this respiratory depression in the PACU seems to really manifest on the floor. And why is that? Well, the PACU is a stimulating environment. The nurses are talking to you, there's machines beeping, there's a lot of action, a lot of activity. Now it's time, you've met PACU discharge criteria, now it's time to take you to the floor. They put you on a gurney, the guy is talking to you and you're bouncing up and down on the thing, it's uncomfortable. You show up in your room, your family's there, the nurse is checking you in, it's a very stimulating environment. Now they tell you, you've had a big day. We're gonna go eat and we're gonna let you rest. And they leave you alone. And that is when the patient falls back to sleep, becomes more somnolent. And then when the nurse goes and checks on the patient, very alarmed, calls in RRT and patients get naloxone. So what to do? Well, I think it's important to understand your patient's risk factors and to minimize extrinsic risk factors. So extrinsic risk factors are things that we do to the patient. So maybe the frail patient, you should push that patient more for a regional technique than a general anesthetic. maybe that patient should have short-acting agents rather than longer-acting agents. And I think it's critical that we educate the floor nurses and the PACU nurses about this interaction between PACU and floor respiratory depression, and to really train the floor nurses not to wake up the patients before they assess the respiratory rate. Also, monitoring and triage strategies. The problem, and I'm not going to go too much into this, with continuous monitoring is there's ergonomic challenges, there's reliability, there's acceptance, and you have to integrate this into your practice. And we all know this is much more difficult than we think. One approach, though, which I like, is considering much more specific parameters and sensitive parameters. One group, they turned the pulse oximeter down to 80%. That would alarm after 30 seconds. Okay, so you have to be at low 80 for 30 seconds before it would alarm. The patients were instructed to take 3 big breaths if the machine beeped at them. By this, the nurses only got 4 alarms per day, and the rate of RRTs went way down. The rate of ICU admissions went way down. And further, the nurses were then able to focus on other patients and provide better care. So they did a model of this where they took more of condition-specific alarms. So they said, what would happen if the alarm beeped at 88% instantly? And we put a delay from 88% down to 80%. They had an 88%, I know those numbers are the same, but they had an 88% reduction in overall alarms. And then if they added 15-second delay, they had another 71% reduction in alarms, which reduced the amount of alarms going off for the nurse from 1.2 hours per shift to 3.6 minutes per shift, so much more manageable. So this is a general approach that we use at Mayo to assess patients. And I think this can be used not just for respiratory depression, but many other factors, is that we need to assess patients and say this patient is either low risk, intermediate risk, or high risk. And then modify our surgical and anesthetic plan based on those patient factors. The PACU is critical for monitoring respiratory depression. The PACU is probably critical for other things too. If the patient is very somnolent in the PACU, that patient is going to go on to be somnolent on the floor. If the patient is agitated in the PACU, that patient is going to be agitated on the floor. If the patient is hypotensive in the PACU, that patient is probably going to be hypotensive on the floor. So look at your PACU patients, and then based on that, as well as the overall assessment of the patient, make some clinical decisions of what are the best options for that patient. Maybe the patient can go to the standard floor or discharged, or maybe this patient needs something more. That does not necessarily mean the ICU. It might mean calling the floor nurses and alerting them that, listen, watch for this patient. I think this patient's okay, but really keep an eye on their blood pressure for, the first couple of hours. And of course, if a patient is on some therapy for a chronic medical condition, so with OSA, if the patient's on PAP therapy, encourage the patient to continue using the PAP therapy on the floor. So I know this was quick. I usually talk about this for an hour at a time, so I'm happy to take questions afterwards. Thank you.